Hello and welcome. The wish lists for India's health sector, particularly from an investment point of view, have always been long. It was generally felt that as COVID-19 advanced on us and created and left the destruction that it did, it would have generally led to a increased spending, greater focus and attention, particularly from federal budgets. Now, that does not seem to have happened. But before we come to that, let's look at what some of the wish lists were. The wish lists were to do with several areas. One is, of course, a fundamental strengthening of the healthcare delivery system, primary healthcare centers, secondary healthcare centers, doctors, equipment, disease surveillance systems across the country, everything that would help you spot a pandemic and perhaps respond to it better across the country. Not that the pandemic or pandemics were the only problem that India's healthcare system, but like I said in the beginning, it was generally felt that COVID-19 and the pandemic that we're still in the middle of would have increased awareness in our now. Now, the Union Budget 22-23 does not seem to be responding to that for various reasons, which some of which we can guess, but we are not sure of. Is it because the pandemic itself is now receding and therefore there is confidence, or is it a belief that the health system will take care of its own and in some other way, and perhaps with greater private sector participation? But let's try and understand firstly what we needed, particularly from a funding and budgetary support point of view, and more importantly, as we look ahead, how is this going to play out? Whether or not there is a pandemic, how will we address some of India's most fundamental healthcare challenges without union budget? So to discuss this, I'm joined by Dr. Srinath Reddy, President of the Public Health Foundation of India, and Yamini Aiyar, President and CEO of the Center for Policy Research. Thank you both for joining me. And Dr. Reddy, let me start off with you. I did read your pre-budget comments, some of which I've pulled from liberally in my opening remarks. And obviously, what came in the union budget was not in that league. So, where would you start off?
Well, pre-budget comments were more in the nature of a prayer rather than a prediction. But I did write even after the budget, expressing a certain amount of disappointment that we did not see a much greater rise in the allocation for health, and in particular for primary health care and for investment in human resources in health. I mean, I did comment on the positive features as well as the possible negative features, which disappointed. But overall, when you look at what the allocation has been, compared to the previous year's budgetary estimates, the allocation to health appears to have gone up by 16%. But when you look at the revised estimates of what was actually spent, the current allocation is only 0.6% over the revised estimates, which is a minuscule raise, which actually shows that despite the capacity of the health system to absorb increased allocations, we have not actually allocated more. And as a percentage of the total budget, the health component is only 2.26%, which actually shows a little decline compared to the previous couple of years. And when you look at what the health ministry itself sought, in the last 2 years, only 69 to 73% of the funds sought by the Ministry of Health and Family Welfare were granted. I don't expect every ministry to be granted everything that they asked for, but there have been certain disappointing features. For example, the National Health Mission, which is the primary vehicle for advancing many health programs in the country and is principally responsible for primary health care, that has not really been given the attention due. There are many other features I can comment upon, but overall, I would really say at this point in time that we have had a mixed budget, strong on infrastructure, and to some extent on technologies, weak on human resources, and relatively inattentive to primary care.
Right. Okay. So we'll come to some of those in a moment. Yamini, your takeaways in terms of where this is going. I mean, how does it look to you from a 30,000 feet point of view?
Thanks, Govind. I think I echo a lot of what Dr. Reddy said just before me. I think this budget was a tough balancing act for the finance minister. At one level, some amount of fiscal space had opened up, which was, I think, somewhat unexpected if you compare with projections as of last year in terms of revenue buoyancy. For the government, net revenues were far more buoyant this year than they had anticipated. But of course, extremely disappointing in the projections for disinvestment of 1,75,000 crores, where the better part of the 1 lakh remains unmonetized or not collected by the government. So in that sense, the overall revenue pool available for the government was somewhat limited. And the challenge was, do we go down the path of some amount of fiscal consolidation after last year's expenditure for this current fiscal and the fiscal ahead? And in that context, what are the kinds of expenditure choices that we ought to prioritize? I think two very important things happened. There was a huge expansion in government expenditure in the first year of the pandemic, going up to about 17.78% of GDP. Last year's budget had expected some amount of expenditure contraction for this year. That has happened. Expenditure contraction was by a whopping 1.5% of GDP, and the fiscal deficit comes down from 9% to about 6.9%. So some amount of readjustment happens there. And then going forward into the coming fiscal of FY23, an attempt was made to be somewhat conservative about revenue expectations, far more conservative and probably realistic about disinvestment, and therefore, moving down the path of fiscal consolidation to further contract expenditure. So it contracts from 17.78% of GDP at the start of the pandemic down to about 15.4%, if I'm not wrong, into the coming fiscal. And in that, clearly, a very clear choice has been made to prioritize capital expenditure over investments in human capital as the pathway forward, both to enhance recovery, get us back onto a growth path, and in some ways the articulation of the Amrit Kal for the next 25 years, because that was a very central part of the budget. In that context, I think, given the backdrop of the pandemic, the fact that we didn't both from the point of view of the budget speeches are an important political signaling, emphasize and prioritize the importance of investment in health. The fact that, especially if you compare with revised estimates of this year to budgeted estimates of the coming year, that the National Health Mission budgets actually are about stagnant. This in the context of the fact that a fair amount of non-COVID related health activity had been under prioritized over these last 2 years. You can see it, for example, in reproductive child health investments. You see it also in nutrition investments, which will come back to in different ways to impact the pressures on the health system. Right. And the fact that we're also not investing more broadly in disease surveillance, epidemiological aspects of preventive and promotive aspects of health, all of which are critical as we have learned from the consequences of the pandemic. So in that sense, this budget is very much a choice of infrastructure and for growth rather than human capital and human productivity for growth.
Right. So let me ask you a more simple layman's question. And before I come to Dr. Reddy, if you were to look at it historically, suppose, let's say, an economy like India leans heavily on, let's say, capital expenditure. It's, infrastructure in this case, which obviously creates jobs, which creates economic activity, which also acts as a spur to other activity, let's say private investment, which has slowed down. Is all of that, can all of that in some ways help support the investments that we need for health? Do people, because people have more affordability, are they able to afford better care? Is there a link in some ways?
Well, I think you don't have to look very far, but to map out the last 30 years of India's economic growth story after liberalization. And in particular, that phase of 2004 through till the global financial crisis, when capital expenditure was relatively high. We were on a growth phase. Some amount of investment through the National Health Mission had led to an expansion of the health system. But all in all, our overall investment in strengthening human capital, specifically health and education, have been limited. And there is enough evidence to tell us that those limited investments are one of the reasons why I think what this is reflecting to me is that we haven't learned lessons of where we needed to invest based on our own rich experience of growth. We haven't learned lessons of where we need to invest based on our experience of the hardships we've had to suffer as a consequence of COVID. Just one data point, we know that growth resulted in an overall lifting out of a large number of people out of poverty, but 50% of those who were lifted out of poverty in that phase, particularly in the 2000s, are what the World Bank describes as vulnerable populations. So one income shock pushes you back into poverty. And we also know that the greatest income shock that most vulnerable households are vulnerable to are health shocks. So without investing in primary health, you are essentially not creating enabling conditions for all Indians to be equal participants in the growth story. I don't think we should be working towards an unequal India. We should be working towards an equal India of equal opportunity and equal growth.
Right. Dr. Reddy, now let me come back to you. Now, in your wish list before the budget and your analyses post-budget, I mean, I think you focused on 3 or 4 areas, of which pandemic is one of them, but you've also talked about health infrastructure, the expansion of tertiary care infrastructure, health research, and of course vaccination or vaccines, which in itself, considering that we could go for or need booster doses, could be a substantial cost. So tell us about how you are seeing priorities going for the next couple of years, and where could we or might we find the funds to support them?
Firstly, let's prepare the frame under which we actually ought to decide the priorities. We have made a commitment to universal health coverage, which means that you need capacity at all levels of care, but particularly at primary health care. You also need good connectivity between the different levels of care. In primary care, we have said that we will invest, even in the national health policy, about 67% of the health budget going to primary care. The same thing was recommended by the 15th Finance Commission. Now, we have not seen that happening, and the principal vehicle for primary care, which is the National Health Mission, has still received only about 48, actually it's come down to 42% of the whole overall health budget from 48%. So unless the National Health Mission is strengthened, we are not likely to see strong primary health care. And especially when urban primary health care has not even been addressed in any meaningful manner, we do need a lot more emphasis than has been given. Then the district hospital strengthening becomes very important for connecting it well in a bidirectional manner to primary care. Perhaps some of the district hospital strengthening will come by way of infrastructure through the health infrastructure mission, the ABEAM, PM ABEAM. But we'll have to wait and see. And also the connectivity will possibly come from the digital health mission, which again has been introduced this year. These are the 2 missions that came up in September and October. But mere infrastructure and digital technologies are not going to provide the human resources that are needed to make them operational. Without adequate investment in the human resources for health, with a multi-layered, multi-skilled health workforce, all the investment in infrastructure and digital technologies will only provide us a carriage without wheels. So we do need that element of it, and we have not seen much of that. Very minimal increase in the National Health Mission component of human resources. But the extensive increase in human resources, both at the primary level and even at other levels, we do not, 63% shortage of specialists in community health centers. So there are many areas of human resources that we should be investing in very quickly. And since you have been talking about the economy, it's not mere capital expenditure and infrastructure that's going to push up the economy. You need jobs. And healthcare sector, which is very short of human resources, is one area which can absorb a large number of jobs with good effect, both on the health outcomes as well as on the economy. So we ought to have been really talking about that, how to actually strengthen district hospitals, make them into training centers for doctors, nurses, and allied health professionals, by way of introducing new training institutions around upgraded district hospitals in states and districts which are underserved at the moment. So there are many things that ought to have been done. Of course, we have seen some welcome things like an emphasis on mental health, but that again is telehealth. But without primary healthcare services being strengthened, they'll only reach one part of the population, not everybody. There are some welcome initiatives, but we need a much more cohesive framework for universal health coverage. We have had assembled some pieces of it, like the digital health infrastructure, but unless we put together all of them together, we are not going to see this functioning, and particularly human resources. Just to give you an example, the Pradhan Mantri Jana Arogya Yojana, which is supposed to provide secondary and tertiary care in hospital settings and provide financial coverage for 40% of the population for the care they get there, they could only spend half of what they were allocated last year. And the same allocation continues, but they could not spend the money, partly because the pandemic prevented some of the services being rendered, but also because their presence in 2-tier, 3-tier, smaller towns and villages is much less. You've been over-dependent on the private sector, and the private sector failed to deliver even vaccines in 2-tier and 3-tier towns and cities. So you have to expand your public sector capacity, particularly the district hospitals. So these are some of the areas of investment I believe should have been made.
Right.
And we need a very cohesive, connected healthcare system between all three levels. But while we have bits and pieces coming up, we do not see the connection very clearly.
Right. Yamini, explain to us and those who will watch or read this, how does it work between the central and the state governments in terms of budget allocations, or where people, or I mean, when I say people, I mean states, find the money to create their own healthcare systems or back them up?
So this is where it starts getting complicated. I mean, at one level, it is true that health is a state subject, and for very good reason. In fact, if you ask, if one were to just look at pure first principles of public finance, I would say that a significant proportion of healthcare services ought to actually be completely decentralized to the local government level. But the Indian Constitution, while it has accorded, rightly so, health to states, also has this, complicated 1/3, 2/3 problem.
Right. Okay. Let me come back to you, Dr. Reddy, before we get Yamini back. So, one of the other points that you've talked about is the frontline workers, ASHA workers. Tell us about, because, and particularly in the context of vaccination or COVID-19 support, they've played a critical role. Tell us about how you see whether we need more investment, or is it better organization?
We need both. Firstly, when we are really looking at comprehensive primary health care, let's remember that the ASHAs were introduced when the agenda for primary care was much more restricted to maternal and child health, to some extent for infectious diseases and nutrition. But that was a very limited agenda fashioned after the Millennium Development Goals. But now we are talking about comprehensive primary health care. It has been said that previously primary health care was only addressing 15% of the health needs, even at that level. Now we are talking about addressing almost all of it, but with the same ASHA, one single ASHA and 1 or 2 auxiliary nurse midwives. You need far larger number. If you want to address non-communicable diseases, mental health, all of these, then you require a much larger number. So, and of course, better skilling as well. But at the same time, we definitely need them to be part of the health system. You can't always treat them as unpaid or underpaid volunteers and expect them to work with the utmost devotion all the time, especially during public health emergencies. I think we ought to pay them more, We ought to organize them more. We ought to skill them more. But definitely our primary healthcare services ought to be better organized. And we are not seeing that at all in most of the urban areas. Rural areas, Ashas have performed well. Rural primary healthcare owes a lot to them. But in urban areas, we do not have a similar mechanism functioning. So unless the National Urban Health Mission is activated strongly, we are going to see deficiencies. And we saw that even during the COVID period. The initial case detection by symptom-based syndromic surveillance of households, early referral for testing, contact tracing, all of these required the primary healthcare workforce. We left the contact tracing to policemen. That's not the way public health should be organized. So we do need to invest much more in the frontline health workers. And when technology enabled, they can do an excellent job. So upgrade their skills as well.
Right. Yamini, we lost you for a second, and I was asking you just before we did are asking you to explain how the federal state mix works when it comes to healthcare investment, and who should a citizen really expect or hold someone to better account?
Thanks. Sorry, Govind. Something unexpectedly seems to have gone wrong with my internet, but hopefully it won't give up on us now. As I was saying, health is within the constitutional schema very much a state subject. But here's the rub. Our constitutional schema has what many economists have called the sort of 1/3, 2/3 problem, where the bulk of fiscal monetary powers rests with the center, while the bulk of the expenditure powers rests with the state. And while there's a very clear public finance logic for why, an accountability logic actually, for why health should be a state subject, and if you ask me, actually a significant proportion of health services should be devolved to the local government level. The best kind of accountability is when government is close to citizens. Given the dynamics of our fiscal architecture, the question of where should the money come from remains a central one. And in this context, the Finance Commission, through a process of tax devolution, is supposed to be the primary vehicle through which funds are devolved on the basis of a formula to ensure both vertical as well as horizontal equity across the states of India. Now, over time, for a host of reasons, the instrument of centrally sponsored schemes, which is essentially a one-size-fits-all model designed and financed by the central government, it's a specific transfer, has become a critical mechanism through which elements of government functioning, like health, are financed by the center. And one of the consequences of this is that while state governments, through their own resources, primarily tax devolution and their own tax revenues, spend the bulk on health, the bulk of that is tied to wages. These schemes have now become the primary source of non-wage finances for infrastructure provision, for purchase of equipment, and so on and so forth. And in fact, we saw over time a fair amount of substitution too, as states, in order to maintain their fiscal responsibilities, substituted for wages through these national schemes. Now, one of the consequences of this, in all practical terms, is that the center has used these centrally sponsored schemes as an interesting vehicle to sort of control almost line by line expenditure at the state level. The National Health Mission began with 5 flexi pools, broad monies that states could use based on plans that made sense for them to spend, all very logical. This has today gone from 5 line items to 2,000 line items. And constraints of accountability or accounting constraints have ensured that it's very difficult to move monies according to needs and priorities across the line items as given by the center. My colleagues Avni Kapoor at Accountability Initiative have traced just the movement of a single file across the different desks in districts in Uttar Pradesh for the National Health Mission, and found that a single file goes through 32 different desks before it gets cleared for the state treasury to release monies for expenditure at the ground level. So all of this creates a context where both states argue, rightly so, that they are losing flexibility to align expenditure to their own needs and priorities. But at the same time, they're deeply dependent on the central funding. So when the center says, well, okay, health is a state subject, go figure, find funds on your own, states complain and they want that centrally sponsored scheme because now we've got used to that. It's sort of how the federal balance has been maintained thus far. And it also then results in a lot of blame gaming. It opens the window for the center to tighten control over expenditure, undermining the ability of states to effectively spend according to needs and priorities, creating a blurring of lines of accountability. And most importantly, I think from the long-term perspective of our health system, we know that in India, regional inequality is significant. The pressures on Bihar are very different. The needs and pressures on Bihar are very different to the health needs and pressures of Tamil Nadu. So we do have to move towards much greater flexibility and creating a context where states can plan to spend according to their needs. That means investing in planning capacity. Unfortunately, in the center-state tussle, rather than investing in planning capacity, the center has chosen to invest in its own capability to tightly monitor line item expenditure, which ultimately undermines implementation and accountability at the grassroots. I think until we don't get out of this very fundamental administrative conundrum and this larger federal context in which this conundrum has unfolded, we will always see a world in which allocations don't always get spent in the way that they ought to get spent.
Right. Okay, let's look ahead and let me come back to you, Dr. Reddy. So this is what we are presented with or have been presented with. If we were to now look ahead, whether or not there's another COVID-19 wave, how do you see the center, I mean the states, center, citizens really adapting or adopting to the current healthcare system with all its existing or lack of resources?
Well, I think over the next few years, we ought to see definitely the center and the states trying to enhance their investments in building up a much more capable healthcare system. I mean, that's my hope. Whether it will happen, particularly if COVID fades away with Omicron, or even the next variant is relatively mild and we start focusing on other things and health slips back again onto the back burner, I cannot really say. But I believe if the lessons have been learned, then we ought to continue our investment in health. While capital expenditure is attractive in terms of showing that you are actually increasing your spending on health, that would be incomplete in terms of its outcomes if you are not actually investing also in human resources in order to utilize the infrastructure and the technologies that are being invested in. So I'm really hoping that there would be a much greater interest in expanding our human resources for health, particularly by training a large number of people who are non-physician healthcare providers but are technology enabled for the primary care, but also investing in other sectors as well. But given that we also have declared that we are going to have an Atmanirbhar philosophy, and which is fairly good in terms of not being dependent upon shaky supply chains, we do need to invest also in having a large number of capacity building initiatives for drugs, vaccines, and equipment, and a much greater amount, of course, in public health, not just disease surveillance, but also in terms of ensuring that there are competent health information systems that we can depend upon, and there are enough number of well-trained public health personnel who can deliver a large number of disease control programs as well as enable health promotion.
Yamini, can I come back to you? You know, if we were to now look at where money is spent, I mean, you know, 80% plus maybe of all healthcare expenditure in any case is in the private space. People spend out of pocket. And as you pointed out, some of the biggest shocks that happen are health shocks or healthcare shocks, and people slip back into poverty. Given this, I mean, would it be maybe right to argue that in going forward, the onus really of taking care of people's health lies more on the private sector, and therefore we should really be focusing our energy and attention on that?
Well, let me put it this way. If you just look back at the pandemic from March 2020, before the number of cases actually sort of hit a large number in India, there was a very clear consensus, particularly amongst the elites, that our health system, both public and private, was far too weak to respond to the enormous demands that COVID that COVID would place upon us. And when we looked westwards to what was happening in relatively better off countries, we immediately said we need to lock down. And look at the costs of that. We locked down in March 2020 and saw the greatest contraction in our economy ever. And the costs of that on the poor are still being paid. So I think the fact of the matter is that our starting point has been a relatively weak health system, both public and private. Both need to be invested in and expanded. But no country has effectively managed to provide equitable and inclusive healthcare to all, following the goal of universal health coverage, which India has recognized as its own goal, without investing in the public health system. You simply cannot rely entirely on a private system to provide health, given the fact that the private system, without effective regulation, can be quite pernicious. And in fact, even with an effective health regulatory system, as we see in the US, can be very pernicious. So we do need to ensure that we have effective investments in foundations, which can only be done through a strong public health system, and that we live up to the goal of universal health coverage, and we ensure that this is equitable and inclusive for all Indians. It's not going to work any other way.
Right, right. Dr. Reddy, last word. I mean, as we look ahead, who's going to bell the cat, as it were?
Well, the people will have to do it. Firstly, I completely agree with Yamini that unless you have a strong public sector, which can actually bring in the private sector as per need and opportunity as a partner, but with a well-regulated framework of universal health coverage, we are not going to see a good healthcare being delivered to everybody. But I believe if we actually bring the local bodies, the panchayats and the municipal corporations into primary healthcare very strongly, then people-partnered public health will generate the momentum for reform. And that will actually ensure not only more money is allocated to health, but there are also utilization efficiencies in terms of the right kind of priorities being set with a lot more accountability. So if you're talking about who will bell the cat, I believe it's the people who will have to exert pressure both on the state governments as well as on the central government by demanding services. And the more we actually engage closer to the community through the local bodies and engage the community as well in designing and delivering the health programs with adequate monitoring, then we are going to see definitely a greater demand for a more competent and compassionate healthcare system.
And hopefully the funding for it, as both of you have articulated. Dr. Srinath Reddy, Yamini Aiyar, thank you so much for joining me today, and do hope to speak to you again.
Thank you.